We shall learn why surveillance after treatment of neuroendocrine tumor treatment is critical for longevity and quality of life. Hello, this evidence-based content is prepared by Saboor, fellowship-trained consultant surgeon. And if you or someone you care about has successfully undergone treatment for a neuroendocrine tumor or NET, you might be wondering what comes next. I know that finishing treatment doesn't necessarily mean you can put the diagnosis behind you completely, and that uncertainty about how long to remain vigilant can feel exhausting. Today we're going to demystify the surveillance journey that follows NET treatment. By the end, you'll understand why lifelong monitoring matters even after complete tumor removal, what specific tests you'll need, how those intervals change over time, and when, if ever, surveillance can stop. You'll walk away with clear knowledge about what to expect in your long-term care. Neuroendocrine tumors are unique in their behavior. Unlike many cancers, NETs are generally slow-growing and well-differentiated tumors, but this characteristic creates a paradox. Even when completely removed, what we call R0 resection, these tumors have a potential to recur many years later. In fact, evidence shows disease relapse can occur 15 years or more after surgery. The surveillance period doesn't just monitor for recurrence. It also screens for secondary malignancies, new cancers that can develop in those with a history of NETs, assesses functional outcomes particularly after pancreatic surgery, and helps manage the transition from active cancer treatment to survivorship. Before we dive deeper, let's establish what we're dealing with. A careful balance between vigilance and quality of life over potentially decades. Here's the critical point. Complete surgical resection doesn't guarantee you're cured forever. Research demonstrates that even with what appears to be successful tumor removal, late recurrences remain a real possibility. For small intestinal NETs, recurrence most frequently occurs within the first 5 years after curative surgery, but cases have been documented up to 15 years post-operation. Think of it like this. Your immune surveillance system needs backup, and that's where medical surveillance steps in. The risk isn't uniform across all patients. Those with advanced disease at diagnosis, such as lymph node involvement or liver metastases, carry higher recurrence risk. Tumor grade matters significantly too. Grade of a tumor refers to how rapidly the cancer cells are dividing after assessing these microscopically. Grade 1 NETs behave more indolently than Grade 2, while Grade 3 tumors require even closer monitoring. But here's where it gets interesting. Even patients with small, apparently low-risk tumors aren't entirely off the hook. Studies on appendiceal NETs show that tumors over 2 centimeters, high-grade tumors, and those with lymphovascular invasion all warrant consideration for extended follow-up, even when completely resected. Your surveillance journey isn't random. It follows evidence-based protocols. For most patients with small intestinal or pancreatic NETs who've undergone curative resection, imaging typically starts 3 to 6 months after surgery. The preferred modality is MRI of the liver and abdomen, chosen specifically because it's more sensitive than CT for detecting small liver metastases, the most common site of recurrence, and doesn't expose you to ionizing radiation. For Grade 1 NETs after initial postoperative imaging, intervals extend to every 6 months. Grade 2 tumors require closer intervals initially. After 5 years of being tumor-free, if everything remains stable, staging intervals may be prolonged to yearly. But here's the nuance. Patients with advanced disease at presentation, those with extensive lymph node involvement or liver metastases, benefit from additional somatostatin receptor imaging, preferably using gallium-68 PET-CT, performed within the surveillance protocol. For pancreatic NETs specifically, morphological imaging combined with somatostatin receptor PET-CT should be performed 3 to 6 months after surgery. Then morphological imaging continues every 6 to 12 months for 5 years, every 12 to 24 months for the next 5 years, that's 10 years total, and then every 5 years thereafter. The intensity modulates according to your individual prognostic factors, tumor grade, as explained, G1 to G3, stage of the disease, dependent on size, local and more distant spread, and if surgery was performed, whether margins were completely clear, meaning tumor was completely removed, and your overall life expectancy. Imaging tells part of the story, but circulating biomarkers add another dimension. Chromogranin A, abbreviated CGA, is measured at diagnosis and serves as a baseline. However, its role in post-resection follow-up is limited because it lacks specificity. Many non-cancerous conditions elevate CGA levels, creating false positives. Using the same assay kit throughout your follow-up is crucial for meaningful comparisons. For patients with functioning tumors, those that secrete hormones, monitoring specific hormones makes sense. If you had carcinoid syndrome, 5-HIAA levels measured in blood or 24-hour urine can indicate recurrence, though their value for detecting local recurrences is modest. For those with carcinoid heart disease history, NT-proBNP measurement once yearly or every 2 years helps reveal development or progression of cardiac complications, supplemented by echocardiography. Biomarker reassessment every 3 to 6 months during treatment monitoring could be useful, particularly to inform whether imaging needs to expand beyond the abdomen. In long-term follow-up, if biomarkers were elevated at diagnosis and normalized after treatment, they may be used alternating with imaging, prompting additional workup if they significantly increase. If you've been diagnosed with a NET, you face a slightly elevated risk of developing other malignancies. Small intestinal NETs in particular may coexist with gastrointestinal adenocarcinomas or breast cancer. This means your surveillance isn't solely NET-focused. Age-appropriate cancer screening for colorectal, breast, and other common cancers should continue as recommended for the general population. Think of it as comprehensive health monitoring, rather than tunnel vision on just one organ system. Pancreatic surgery, whether it's a Whipple procedure, distal pancreatectomy, or enucleation, carries long-term functional consequences. These aren't necessarily complications, they're expected changes. New-onset diabetes mellitus occurs in a significant percentage of patients, requiring ongoing glucose monitoring and potentially insulin therapy. Exocrine pancreatic insufficiency manifests as difficulty digesting fats, causing diarrhea, weight loss, and vitamin deficiencies. Pancreatic enzyme replacement therapy addresses this, but requires lifelong adherence. Your surveillance visits serve dual purposes, monitoring for recurrence and managing these functional sequelae. Nutritional assessment becomes part of your routine, checking for deficiencies in fat-soluble vitamins A, D, E, and K, as well as vitamin B12, niacin, and standard nutritional parameters. If you're supporting someone through this, understanding that their dietary needs and digestive capacity have permanently changed helps you provide appropriate support. The psychological shift from active treatment to survivorship isn't always smooth. Many patients experience anxiety, heightened anxiety before scheduled surveillance imaging. This is completely normal. The transition involves learning to live with uncertainty while maintaining vigilance. Follow-up occurs in specialized NET centers or hospitals with close collaboration with NET experts. Regular tumor board presentations ensure multidisciplinary review, particularly if there's recurrence, progression, or other relevant problems during follow-up. This is where honest medicine requires saying, "We don't definitively know." Current evidence doesn't establish a firm endpoint where you can confidently discontinue surveillance entirely. For patients with small, low-risk rectal NETs, specifically those under 10 millimeters, grade 1, without lymphovascular invasion, who achieved R0 resection, follow-up may not be necessary at all. This represents the exception rather than the rule. For most other NET patients, particularly those with small intestinal or pancreatic primaries, follow-up may need to be lifelong. The intensity decreases over time, transitioning from every 6 months to yearly, then every 5 years, but complete cessation isn't currently recommended based on available evidence. Research continues to refine these recommendations, and your individual risk profile, discussed in your NET multidisciplinary team, guides personalized decisions. Request a clear surveillance schedule from your NET specialist. Ask specifically, what type of imaging will I have? How often? For how long? What biomarkers are being monitored? Having this written down reduces anxiety and ensures you don't miss appointments. If you've had pancreatic surgery, schedule nutritional assessment if not already done. Start taking pancreatic enzyme replacement if prescribed, about 25,000 to 40,000 lipase units with meals, and don't skip doses. Come prepared with these questions. Given my specific tumor characteristics, what's my risk of recurrence? At what point might we consider extending surveillance intervals? What symptoms should prompt me to contact you between scheduled visits? Do I need screening for other cancers beyond standard recommendations? If you're experiencing digestive symptoms after pancreatic surgery, ask, could this be exocrine insufficiency? And should I adjust my enzyme dosing? Contact your NET team immediately if you develop persistent abdominal pain that's new or different from before, unexplained weight loss exceeding 5% of body weight, jaundice, yellowing of skin or eyes, new-onset diarrhea that doesn't respond to usual measures, symptoms suggesting carcinoid syndrome such as flushing or wheezing if you didn't have these before, or any palpable abdominal mass. These don't necessarily mean recurrence, but they warrant prompt evaluation rather than waiting for your next scheduled appointment. Let me quickly recap. Long-term surveillance after NET treatment isn't optional. It's essential because late recurrences can occur decades after apparently successful surgery. Your next step, ensure you have a clear, written surveillance plan that covers imaging frequency, biomarker monitoring, and functional assessment appropriate for your specific NET type and risk profile. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here, which you may find valuable for further information on this topic. The European Neuroendocrine Tumor Society consensus guidelines for follow-up and documentation provide comprehensive, evidence-based recommendations. The ENETS guidance papers for specific NET sites, small intestinal, pancreatic, appendiceal, and colorectal, offer detailed protocols. Full links are in the description below.